Hi, welcome to Neuroverse, a podcast hosted by Carolina
and Clara, where we discuss all matters from neuroscience to philosophy and beyond.
In today's episode, we are celebrating Women's Day by discussing the current state of women's reproductive health care and research, how much progress has been made, and what still needs to be done. We are joined today by Professor Sohier Elneil, a UCL Professor and Consultant specialising in Urogynaecology and Uroneurology. Professor Elneil completed her PhD at the University of Cambridge in the physiology and pharmacology of sensory bladder dysfunction in women, and now runs the neuromodulation program for bladder and pelvic floor dysfunction at the National Hospital for Neurology and Neurosurgery, as well as actively teaching at the University College London and the Royal College of Obstetricians and Gynaecologists. Welcome to the podcast, Professor.
Thank you very much for having me. It's a pleasure to be here.
Thank you so much for joining us, especially for this special Women's Day episode. It's going to be so nice to have your expertise to discuss this topic that is very important, especially to us.
Thank you.
So to start us off, we'd love to hear a bit more about your PhD topic and how you got into it.
Okay. So I think it might be important to have an idea about my personal journey and history in medicine and how I got to where I was and why I did the PhD at Cambridge in that specific subject. So I was trained in Africa. I went to medical school in Africa and then did my undergraduate and also my initial postgraduate house officership work in Africa, and in particular where my parents were based at the time, which was in Ethiopia. And in Ethiopia, there's a very famous hospital known as the Addis Ababa Fistula Hospital, which deals with childbirth trauma in young women and girls. And one of the most sort of devastating conditions is something known as an obstetric fistula, which is a communication between the bladder and the vagina and the rectum and the vagina. So it's a sort of it creates a significant problem for women because they're leaking and their lives are pretty much not that great. Now, obviously, having been interested in surgery, my interest was, if we can surgically repair this is amazing, then everybody will be fine. But I found that despite us doing surgery and learning how to do the surgery, it became apparent that despite fixing the hole or the anatomical problem, women were still suffering with problems with incontinence, chronic pain, recurrent infections, and so on. So then I came back to the UK and I was at Addenbrooke's Hospital in Cambridge and actually training in obstetrics and gynecology. And I realized that there was very limited science into why women's pelvic floors, should I say generically, were so damaged during childbirth and what actually happens to them. Now, at that time, there was a belief that, it's all muscle and, if you fix the muscle, everything will work. Well, we know that muscle is an effector organ. It responds to nerves. So I started thinking the nerves have something to do with this, and we need to really be looking at the nerves. So I decided when I had done a sort of a proportion of my training to look at the further science of this, and decided to do a PhD in pharmacology, looking at sensory mechanisms in the bladder, in particular, looking at purinergic signaling and changes in purinergic signaling. And at that time, it was quite novel thinking because purinergic signaling, particularly ATP, was considered not to be something you saw in the epithelial lining of the bladder. It was something that was believed to be predominant in the muscle layers of the bladder. And so therefore, there was a lack of understanding that actually the neural content and what happened to the nerves as they went into the bladder was they actually went into the epithelium. So therefore, purinergic signaling wasn't happening at the muscle level, but it was actually happening at the epithelial level. And this was extremely important because it then explained to us that that was really the little brain in the bladder. It wasn't actually in the muscle. It was actually in this sort of lining. And I remember when we tried to publish our first paper, there was such resistance to it because it wasn't normal thinking. Everybody was like, no, that doesn't happen. And it wasn't until a few years later that the American group actually saw that this was the case. And that changed the way we thought about everything. Now, take all that information about the fact that the nerves are so important. And I thought, well, I'm a surgeon. How am I going to use this information to change women's lives, particularly women, because I was very interested in all the dysfunction elements. And that's how neuromodulation came into it, because at that stage, neuromodulation was in its infancy. In the UK, in the early 2000s, there was only 2 hospitals that were doing it. One was in a place called Macclesfield, Pinderfields Hospital. And here at the National Hospital for Neurology and Neurosurgery, one of the neurosurgeons had been implanting the device mainly on the say-so of colleagues trialing it. So between 1997 and 2004, they'd implanted 30. But the patient selection wasn't very well defined. And we started to look at that. And then when I came in 2004, first of all, there was new modalities of therapy in neuromodulation, which I adopted. And so I was the first person to implant a particular type of sacral device. And then after that, it literally took off. So we went from a situation where there were only 2 hospitals in the whole country doing this, particularly for bladders and pelvic floors, to now every hospital in the UK being commissioned to do this. Wow. So it has had a really significant impact on women's lives, and it's changed the way we do things.
Wow, incredible.
Mm.
Yeah, as scientists, it's amazing always to hear how basic science can really be applied in medicine. So yeah, that's an incredible story. I was wondering, how common are these fistulas that you mentioned at the beginning?
So fistulas, in particular in under-resourced settings where there's lack of access to antenatal care, particularly, and also young girls are married off at a very young age, are fairly common. And it was very difficult to work out the demographics because we didn't have the right denominator. So we didn't know actually how many women of that age group were having children. We didn't know how many women were therefore having fistulas, because a lot of them were in rural areas and so on. So the only time you were aware of the problem was when they managed to reach various hospitals. And in Addis Ababa, there was this particular hospital. And I know personally, having worked there on and off for many years, we were roughly doing about 1,000 operations a year. So we know there's at least 1,000 every year, but it's actually far more than that. And it's about getting people to come to the hospital. And when I got involved in this arena, I sort of worked on a global level, developing competency-based training manuals on how to do the repair, etc., and bringing in the whole world, as it were. So all of Africa became involved, Asia became involved, and we developed the skill sets. And until now, we do this work, and it's supported by multiple UN agencies, USAID, different philanthropic organizations throughout Africa and Asia. So the problem still persists. We still don't know the real numbers, but we work together with the World Health Organization to make it a reportable condition so that people will now report it. At least we'll start to get some data. We still don't have good data.
Wow. It's interesting to me how in the beginning there was this resistance in shifting the mindset. And I think that this is common in a lot of paradigm shifts, but also specifically anything that relates to women's health and a kind of attitude of if it's not broken, we don't need to fix it, even though it was broken. So it's amazing how you took this thinking about how the nerves are related to the muscles and therefore how to take this problem further. I was wondering, in terms of these, in terms of the neuromodulation, could you tell us a bit more how it works? And I guess what are some of the data that you're looking at and how you can take that further?
So neuromodulation is quite an expensive technology, but it's not that dissimilar to a heart pacemaker. but you insert a very fine wire which lies along one of the sacral nerves, preferably the third sacral nerve, and then it's connected to an external system. So it has a trial phase. And initially the trial phases were roughly 1 week, 2 weeks. And I realized with women, you needed really about 4 weeks because you need things to really get to work, because we are complex creatures. We don't just have a bladder or a bowel or a vagina. We have all three, and they all need to work together in order for us to have a successful management of our organs, as it were. So once you put that in and you trial it, what you're looking for is restoration of sensation. You're looking, do you get the right sense and the right messaging in your bladder? Or if it's done for fecal incontinence, for instance, in the lower rectum. Do you normalize your pattern of behavior? So instead of going multiple times, for instance, with the bladder, it's expected you'll go 5 to 6 times a day. But some of our patients were going 20 times a day or 30 times a day. So their life was really disrupted. So does it bring it back into normality? Then in patients who can't pass urine, so there are certain conditions where they can't pass urine at all, do they start to pass urine? So it's a very interesting modality. And some of the initial research was particularly looking at the functional aspects was done on functional imaging by my predecessor in the department, Professor Claire Fowler. And what we found was when you implant the device, the control mechanisms in the central nervous system, so in this particular case, it's the periaqueductal grey matter and the pontine mechanician center, which hitherto have been attenuated. You don't see them light up in a fMRI study, suddenly start to light up. So actually, it was that reconnection between the peripheral system and the central system that reinstated normal function.
Amazing. So linking to that, what causes the dysfunction initially? Because obviously the relationship between the brain and the bladder seems to be, like, as always, quite complex. Similar to the microbiome, it's like it can be bidirectional. Is that same? And for this, and linking to that, like, what causes these deficits in the first place? Does it begin in the brain or in the bladder, or, both?
So I think that's a really important question, because actually the big question is, what is the switch mechanism that's been switched off or on or hyper, increased? What is it? And that's a very important point, because nobody really knows exactly where the switch is. There's thinking that it might involve opiate receptors, in particular the mu receptor in the spinal cord. There's belief that it's related to physical change in the bladder. Things alter because of something else, But actually, at the end of the day, I think it is biodirectional, because if you look at issues, particularly if you look at, let's take chronic pain, which is another arena I work in, and also the neurological dysfunction in that area, is that it is not often one factor. There is definitely a biopsychosocial component to it. And I think in women in particular, actually every problem we have, there's probably a biopsychosocial component in it. So I would agree that it is a bidirectional model. There's something that could have been triggered off, habits of toilet training, for instance, could trigger off how you behave in later life, being under duress, and even things that we don't like to talk about, but we have to talk about, which is violence against women and girls, impacts on how your pelvic floor functions. So all of that sort of psychological situation, the social situation, some women, if you ask them, do you want to go to the bathroom in a public area? They'll say no, they'll hold on all day. They will refuse to go somewhere in a public area. They want to go home and be in private. So all of that has a bearing, I think. But then that's all neurological, because that is all influence of the centers by other centers in the brain. So I think the brain is a key component. And then you get possibly a secondary effect, unless you've got direct trauma to the pelvic floor. So I think it is difficult to say, a bit chicken and egg, which one goes to which.
Yeah. It's interesting that you brought up the biosocial component to it. I think that's very much present in anything that relates to women's issues. But first, I think I would like to talk a bit more about the pelvic floor and bladder dysfunction in general. I think that the pelvic floor to most of our listeners is probably like a mystery word. What does it mean? It's this abstract thing. So I guess what is it composed of? And I guess what's its role?
So I think the best way I would say to your listeners is put your two hands together. And if you put your two hands together, you'll see you've got fingers and so on. You have to imagine all your fingers are different types of muscles, and all of them are sitting together aligned. And actually, putting your hands together is roughly the size of your pelvic floor. And as long as it's intact and you've never had children, it will stay nicely, and it will be like a nice little cup, and it will hold the pelvic organs. But if you have any trauma to it, in other words, if you have a baby, which is a beautiful event, but it can also be traumatic in a sense. If you have problems like chronic constipation, severe asthma, chest infections, all of those pressures in the abdomen and the chest are transmitted to this little pelvic floor, which it does an amazing job holding everything up. But you can see that if you have constant pressure, it is going to be a problem. And the reason for that is you have got three natural defects in the pelvic floor. One is to allow the urethra from the bladder to go through it. The second is to allow the vagina to go through it. And the third is obviously to allow the rectum and the anus to go through it. So those are your natural defects. And so the muscles work around it, they clamp shut around it, hence all the sphincter action and so on to maintain that integrity. So if you disrupt the integrity, so if you go and, if you have a difficult childbirth, or if you have, chronic constipation, for instance, you will disrupt that sort of really nice, strong sling of support of your muscle group. And therefore, that's when incontinence can become a problem. Prolapse, which is when things start to herniate through the different layers and so on, can become a problem. Now, what's interesting about that is most women who get those problems are often told, normal. Mm-hmm. It's normal. Don't worry about it. Forget about it. Do a bit of physio and your life's fine. Well, we know that's not the case. Otherwise, there wouldn't be a whole field dedicated to it.
Could you tell us a bit more about, I guess, how common are these problems and chronic pain and the dismissal of women, and I guess how we can do better in general as a society, and validate women who feel these things?
So I think there's a very nice statistic that's easy to understand. 50% of women who have children will develop some form of symptomatic prolapse. In other words, and that's a lot of women. Most women will have children. Some don't, but most will. And so therefore, if you think 50% of them are going to have a problem with the bowel or the bladder herniating through, that's quite a lot. And the womb also coming through, that's quite a lot. Then if you look at the attitude towards it, people will say to you, it's a natural part of childbirth. And then if it becomes more evident as you get towards the menopause, and we'll have to come to the menopause as well, because that's a new arena that's suddenly taken off. If they get older, the ligaments obviously become much looser, the pelvic muscles are looser, then all those issues are worsened as they get older. They say, well, that's the natural part of aging. Well, it's, in my mind, it may very well occur because of aging, but it isn't natural to have to live with it. There are solutions and options that you can undertake. And what's interesting for me is that many women don't really get to learn about their bodies until they have a problem. And often it's years later after they've had children. So I remember in 2014, 2015, I had to write a report on incontinence and prolapse for the chief medical officer of England at the time. And one of the things we were trying to promote was the role of physiotherapy and pelvic health for young girls from school age upwards, so that we know what our bodies are like, understand what we need to do. And just like we're expected to look after our bodies by exercising, exercise the pelvic floor as well, and strengthen it and keep it strong, and make decisions that benefit you and your pelvic floor, rather than generic decisions that benefit the way it's always done, shall I say. Mm-hmm.
I have a lot of follow-up questions, but I think Clara does as well. Yeah, I've had a lot of thoughts, but I was thinking about, from everything you've said, it seems like general mindfulness practices could really help with just understanding our own bodies. And as somebody who is very interested in yoga and practices yoga quite a lot, this has really helped me personally, like realize what my pelvic floor is, because there's a lot of like meditations where they say, oh, you know, focus on your like pelvic floor, your Muladhara chakra. And I'm like, what is this? Now I understand more after practicing. Yeah. And well, I had so many other things to say. Oh, yeah, that also on that note, like I have experienced through adolescence as well, realizing a lot of my friends like not understanding really their own bodies and not really being taught about these things or encouraged to talk about these things. And I think that this sort of education could be so useful for preventing these sort of problems.
I would agree. I mean, I think one of the, I think young women now want to understand a lot more about their bodies. And also, there is a tendency to think it's only something that affects certain young women in certain settings, and that's not true at all. So I do a lot of work also with the female genital mutilation community. And I was recently listening to 2 survivors from Kenya. And it was very interesting to listen about how they felt. These are young women, they're in their early 20s, and they are driving the agenda in Kenya for education, replacing FGM with education, but also really educating all the members of their community, and they are speaking to everybody, to the men, to the women, to the girls, to their leaders, etc. And it is changing practice. It's an uphill struggle. Now, you might say, well, FGM in Kenya, what's that got to do with, you know, pelvic health in the UK? It's exactly the same issue, because the same people you need to speak to in Kenya are the same people we need to speak to here. We shouldn't be ashamed of it. We shouldn't sort of hide it. I remember in 2009, there was a big campaign on incontinence to sort of even just use the word, you know, and I was asked to sort of be part of that. I remember speaking on various radio forums and television and so on. But what was interesting is nobody wanted to use the word incontinence. So they referred to it as sensitive bladders, you know, a little trickle, a little this, minimizing the impact on women. And actually, we need to talk about it in its real terms and how much it impacts women. So prevention is key, but also a lot of women, unfortunately, have not been through the prevention. So management is key. And the management can be very simple sometimes. Just knowing what to do is key to actually improving your quality of life.
Amazing. Yeah. Speaking about it and naming it is so important to actually give voice to it.
Yeah.
And as Clara was saying, I also relate to having a lot of female friends that have also felt that they didn't know enough about their bodies, and when they did go to the doctors, they would very much dismiss them with their problems. And you know, these are, like you say, young women who probably haven't had any significant traumatic events, haven't had given childbirth, and yet a lot of them already have a lot of chronic issues. And maybe it's because there's more awareness around it, but do you think that there's a sense that things are getting better? Are we simply reporting it more? Are we addressing it better or not? Like, what is your opinion on this topic?
I think we talk about it more, which is great. But I do think every time I think we've gone, you know, 5 steps forward, I always feel we are pushed back 3, not even 2, 3, you know. I feel we have to sort of go over the same ground again and again and again. And there is a reluctance to accept that what we have said and what ground we have achieved is not only acceptable and we should move forward from that, but it's almost there's a pushback effect. And if you look at things like the background on reproductive health rights, abortion rights, etc. And you see, after we'd made such huge movement in the last 50 years, and now we're back again to justifying them and so on, it's still about choice. And sadly, a lot of women are made to feel bad about making choices, which actually for them are critical at that stage. They should be supported, not persecuted for them. And I think it's the same with all the benign conditions. So I think in women's health, we focus hugely on the pelvic floor, but look at women's cancers, look at women's heart disease, look at women's anything, actually, even social status. I was listening today that, a woman's pension pot, she has to work an extra 19 years to have the same amount of savings as a man at the same age. So, the discrepancies and the inequalities are phenomenally huge. And that impacts not just on the status quo as where we are, but impacts on when we try to get even more information, in other words, in research and so on, very, very much so on our funding access and our wealth access and so on. There's a huge amount that has to be addressed.
Absolutely. So, very well pointed out, the inequality in socioeconomic standing. I was also wanting to address, so some people may complain or critique that when it comes to women's healthcare research, there is a big focus on reproductive health. My opinion is that, it is fundamental to being a woman. And yes, there's many other topics that still need to be addressed, like autism and immune conditions, disorders that are separate or may not be separate to reproductive health. But how would you say that reproductive health ties into the whole well-being, and why it's very important to be in the center of research towards women?
So, I think that's a really important question. So if you look at reproductive health as a whole, there's a huge amount of focus on contraception and pregnancy prevention, which is all well and good. There's a huge focus on cancers. There's a huge focus on premature babies. And there's a reasonably large focus, particularly in sort of under-resourced settings, on hemorrhage after childbirth. Now, if you look at that on looking at the whole female reproductive cycle, those are just really 4 pointers on the system. There's no discussion about menstrual dysfunction and all the issues that go with menstruation. There's no discussion about all the hormonal dysfunction which women suffer their entire life, even if you have perfect periods occurring on the same day of every month, whatever it is, you still have got fluctuations. There is no discussion about hormonal manipulation to support you through those processes, and it's not seen as always as acceptable. So if in certain cultures, if a young woman or a young girl is having problems with periods, it's not acceptable to put her on hormonal treatment. So you need to look at the cultural shifts and changes in that. And then, of course, recently in the UK, menopause has become big news. And because it became big news, suddenly there's a lot of funding in menopause. But menopause has existed since man started. And, for years, menopause was considered as an excuse for women to not cope with life. And it was like, oh, well, she's menopausal and dismissed and discarded. And yet I know there are many people, even here at UCL, who've worked on menopause for decades and were completely ignored, and their funding was always minimal. And it's only now that it's become, shall we say, a sexy topic that people are actually funding it, So we do have to focus on the fact that reproductive health, yes, is addressed, but the 4 issues they wish to address are very specific points in the women's health. But it's not the only points. And that's what we're talking about here. That there are so many other facets to being a woman that are ignored totally because they're considered natural or normal. And definitely my field is one of those. So getting funding in my field is almost impossible. There's always a reason why it doesn't need to be funded.
Yeah. I wanted to ask on the topic of menopause, just because you've mentioned it a few times now, but what are the major problems that you deal with in this menopause period and major like management strategies or treatment for them?
So when you speak to women about this, I'm astonished how many of them say to me, I have symptoms of. Now, traditionally, the symptoms that everybody knows are hot flushes and night sweats. Those are the two. They don't think of libido, cognitive impairment. They don't think of exhaustion, fatigue, etc. And joints, for instance. A lot of women get really severe joint dysfunction and real joint pain. And when they go and see their GP, the GP, interestingly, not all of them, but a proportion of them, will say, well, I don't believe in HRT. Well, it's actually not about your belief. It's what the woman needs. I don't think you should have it because it's risk. There's a risk problem with breast cancer. Yeah, that's true. There's a bit of an association, but if you have your regular mammograms and checks, you should be pretty okay. And often they will say things like, don't you think you might be just a bit depressed? And add antidepressants to their sort of litany of medication. So there is a very dismissive approach. And this isn't just male GPs, because a lot of people think it's male. Even young female GPs can sometimes say, well, I don't really think this is an appropriate thing for you. And I think this is, again, coming back to women's choice. It's all very well taking a decision on their behalf, but you need to inform them. Say, well, actually, you've got reduced libido, cognition is affected, you're exhausted. This is a high-flying lawyer judge. It doesn't have to be. It could be anybody. And suddenly she can't make decisions, but she's been making decisions for a long time, So that's just an example of a particular type of person. But it's actually all women in everything. The woman who says she leaves her house and she can't remember why she left. What? This is a woman who's run a family for years. Suddenly she doesn't remember where and it's not Alzheimer's because that's the usual go-to, it must be that. So it's so important to talk about it, but to talk about all the other soft symptoms, not just the two main symptoms, all the other little minor symptoms. And actually a lot of women, once they start some form of HRT, are shocked what a difference it does for them. And suddenly they're back to where they were pre-perimenopausal states.
What's HRT?
HRT stands for hormone replacement therapy, and it's a combination of hormones to try and get you back to where you were before you lost them.
Okay.
So is the main, because obviously, like if you report these symptoms as a woman who's going through menopause, they could be treated as separate things. Like, as you mentioned, that's what often happens.
Yes.
So is the benefit of considering them part of menopause that you can then go for like different treatment options like HRT that will then target many of these symptoms altogether?
Correct, yes. But again, I would say it's choice. You can offer a woman and say, look, I could treat your hot flushes separately. I could treat your exhaustion separately. I could treat, etc. But I think this is probably hormonally related. Shall we do a trial for 3 months and see what happens? And just do something simple like that. And actually, most women within 3 months, they can tell you absolutely that their life is changed.
Yeah, I like the emphasis on women's choice because I do agree this is the most important for everything we've spoken about so far. Yeah.
So this has been brought up a lot, and I think the answer is clear, but do you believe there's a problem with funding allocation? And if so, what can we do about it?
So I think funding generally across the spectrum of medical disorders is generally focused towards cancer. And now, obviously, conditions like Alzheimer's, Parkinson's, and so on. Alzheimer's is a big one. And I think that comes from the fact that there's a big drive in government. So what I would say is policy often drives funding. And so women's health, as you know, last year there was the publication of the Women's Health Strategy. If you read it, it's quite generic. It's not very super specific in a way. It sort of covers all aspects of women's health. So actually, if you're, but it does cover menopause significantly. So if you're a funder, you're going to think, well, I've read that strategy. That's a policy document coming out with the support of the government. I'm going to focus on this aspect of funding this. So I think the problem becomes that if it's not about cancer and it's not about, premature babies, for instance, it's going to now be probably about the menopause. So a lot of other conditions are kind of ignored. And it's about what is the topic that they want to, what's going to give us the press. And after all, as a funder, you want a deliverable. You want to be seen to be working at the top end of what is needed by the policy drivers. So it's important. And this is why I think you can't do research without being involved to some degree in policy development. And to do the policy development, you kind of need to do research because you need to show the evidence. But also you need to be available. If governments come to knocking on the door, universities come knocking on the door, agency groups, you need to engage. Yeah, that's the only way we can change it.
Amazing. Completely agree.
Yeah.
Okay, so you are involved in several professional international organizations, such as the European Association of Urology, International Continence Society, International Urogynaecology Association, and Pan-African Urological Surgeons Associations. I was wondering, have you observed like a common theme in areas of neglect of women's healthcare around the world? And also, have you observed whether certain topics affect certain areas more than others?
Oh, certainly. I would agree about that. So first of all, I think the first thing I would say is almost all the organizations tend to be male-led or male-heavy. So trying to change that balance has been quite a key thing with a lot of them. They are looking into it themselves. So some organizations are insisting for at least 30 to 50% representation on every committee, in every position and so on, which I think is a good thing. It's still a work in progress. We're still not there, but we will get there hopefully. In regard to women's health, the focus on matters of incontinence and prolapse, it fascinates me that the focus is often on the really scientific aspects of understanding how this works or doesn't work, etc., or there's a new medication in town, we'll run a trial. But actually, there isn't a lot of work on what the women want, because it's all very well we do all this research and we do all these trials. But actually, if you look at, I'll give an example, overactive bladder, which is when you have this rushing to and from the toilet, it impacts on your life. A lot of people think if we can just give you this tablet and it will be fine. But a lot of the tablets have side effects. They make your mouth dry, they make you uncomfortable, and so on. And a lot of women, compliance-wise, is poor. So you would have spent a lot of money in devising a new therapy, but within 2 years, most women are off it. They don't want to do it. They say, I'll just wear pads because I can't be bothered with this, So it is very interesting that a lot of the work we do in these fields do not include patient voices, women's voices. What does a woman want? What is she trying to achieve when she has a significant problem? Another area which I'm going to bring, which is quite topical in the UK, is the issues of the complications women suffered as a consequence of a particular surgical technique involving mesh, which is a foreign substance which was inserted to support bladders and pelvic floors and so on to treat prolapse and incontinence. But nobody actually asked the women, do you want this? They were just told this is the best thing. Now, as a consequence, there was a huge problem with complications. The complications initially quoted were between 1% and 3%, but actually we did a paper which showed it was closer to 10%. And then if you look at the sort of denominator of how many implants were done in the UK, we think it's somewhere between 200,000 and 300,000. So even if we just took 10% of 200,000 to 300,000 women, that's a lot of women with complications. And the surgery to remove the meshes or to deal with them is horribly difficult. But on top of that, they suffer chronic pain, they get recurrent incontinence, they get infections and so on. So these organizations, it was very interesting. I was sort of working on this field for a long time, particularly from the interest of the patients' voices, the women's voices. When I went to some of the organizations and said, look, we have a problem. We need to discuss this and we need to bring it to the fore. There was a huge degree of resistance. And they were very reluctant to discuss the issues because they felt it was just a small proportion of patients who had the problem and therefore it wasn't relevant. And it took a few years before they changed their stance. So they went from sort of basically telling me not to discuss it, to now they have their own forums and groups and committees looking at how to improve care for women with these conditions and how to manage complications of mesh and so on. So yes, so the organizations are critical for dialogue, but sometimes they stifle dialogue simply because they feel it's not going in their direction. But actually, credit to them, they will, as the evidence builds up, change their mindset and come back and say, well, actually, we would now like to look at this in a different way. But I would reiterate, in medicine as a whole, and in fact, in anything we do, if you have a target audience you're speaking to, get their feedback first, speak to them, and then deal with it from that perspective.
Amazing how, 2024, and we still need to remind people that women have a voice of their own and that they don't need to be infantilized and don't need to have decisions made for them. As long as they're informed, they can then choose what they want to do.
Exactly.
Yeah.
Yeah, it's a really good point. I have one final question. Since you've mentioned policy making and, bringing the research to the policy and the clinics, and you've also been involved in Urogynaecology, both in the UK, but also in Africa and Ethiopia specifically, as you mentioned. And you've also mentioned kind of the global disparities or differences in women's health because of various factors, but also cultural differences and things like female genital mutilation in Kenya, like you said. So how can we address these global disparities in women's health?
Big question.
Yeah, I know, it's a very big question.
it's a whole other podcast. But I think generally the principles are the same. Listen to the women. It doesn't matter where they are, in what country, in what situation. Listen to what their problems are. Ask them. Because I've used the examples of these are specific countries, but actually FGM is not just pervasive in Kenya, it's pervasive in Somalia, in Sudan, in Egypt, in Malaysia, in all sorts of countries. People don't expect it to be within different communities. So first of all, ask the women that you're trying to help, what is the problem they would like to address? So in some countries, for instance, it's period poverty. In some countries, it is the issues with fibroids and fertility. Let's address the issue you want us to address first. Then how would you like us to address it? Are you looking for more surgical access? Are you looking for health access? What are you looking for? But actually have your focus group as your guide. So that's step number one. You then develop, based off the back of that, your policy documents that you have now developed with this group of women. And usually there are multiple agencies that like to engage in things like this. So you get them involved as well. They often will help fund those forums and support them. Take those documents to a government level because it needs to be sustainable. So if I, decide I want to do this, me on my own, I'm not sustainable. But a government or an institution like a university is sustainable. So once you get it into those doors and it becomes part of a national health framework, because eventually that's where you need to get it to, and it needs to be in cases where it's not a reportable condition, make it a reportable condition. This is all about data collection and data responsibility and accountability. Then you can effect the change that brings in the funding that can then benefit what the women wanted in the first place. Now, that journey can sometimes be really short, a matter of a few years, but sometimes it's 2 or 3 decades in the making. Yeah. And it's that problem that we're, I agree with you that it's 2024. We should be able to do this in a month, but it doesn't happen like that because there's so many different steps to go through. But that's not an excuse. That's just a restriction. So you need to see if you can hop, skip, and jump through them as quickly as you can with the teams that you work with. So collaboration is key. Getting the right people around the table is key, and making them listen to you, because often you've got the evidence from the audience that needs that help.
Yeah, and at the seemingly obvious but underrated starting point of giving women a voice.
Exactly. I mean, for me, it's always been how I've worked. So I was trained the old way in a sense that, you go in and you just offer this and that's fine, to realizing that didn't really work for me. I needed to listen to what they really wanted. And I'll give you a really sort of dire example. It's a bit sad, but it's also important. I remember working with a colleague who did a lot of work in northern Nigeria on women with fistula. So coming back to the fistula stories, these are women who were leaking urine, etc., etc. And so they were offering them surgery, doing all this surgery. But what the women found is after the surgery, they had so much scarring, they weren't able to have relationships with their partners. So their partners left them. They weren't able to get pregnant. So that was another issue. And these are young women, remember. So most of them get these problems in their late teens, early 20s. As a consequence, they came back to the hospital and said, I wish you had left me wet, because at least if I was wet, I was able to still have normal relations and so on. So it was a really sad situation because nobody'd asked them. Everybody thought they wanted to be dry and they wanted to have the surgery so that they would be dry. But actually the women were saying, actually, no, it ruined the rest of my life. So I'm not sure this was the right thing after all. So it's very interesting. Had they spoken to the women, they would have said, look, this might happen to you, and they could have made a proper informed choice.
Yeah.
Yeah.
This has been such an informative episode, Professor Sohier, and I hope that we're all feeling inspired and armed with this amazing framework that you laid out in terms of policymaking and basic research and women's voice, and be able to, tackle these problems one at a time, and hopefully over the years to come, we'll get there. There's so many more interesting topics and questions I have, but we'll leave it at that for today.
Thank you very much for having me.
Thank you so much for sharing all your stories and also for everything that you do for this field. Very admirable.
Thank you so much. Thank you so much. That's very, very, very kind of both of you. It's been a pleasure.
We hope you enjoyed today's episode. Please feel free to check us out in our socials, Instagram, Twitter, neuroverse_pod, and our website for further resources, neuroversepod.com.
Thank you for listening.